Hello friends, I am Dr. Deepak Garg and today we will discuss classification of bone tumors. We will discuss WHO, AJCC and Enneking classification system for bone tumors. So if we have any patient in the OPD with this bone lesions and we think about the various differential diagnosis in this case, so the differentials that we are thinking are part of which classification system, where they fall under the classification, is that terminology and classification system globally recognized? So do we have answer to all these questions? So the WHO classification is the gold standard reference for diagnosis of bone tumors. They first gave the classification of bone tumors in 1972, which was based on histology of the tumor, means the origin of cell and products of their proliferating cell. Then they updated the classification in 1991, 2002, 2030 and lately 2020 based on the various parameters including histological progress of the tumor, understanding of the biological potential of the tumor, means the behavior of the tumor, whether it is aggressive or mild, evolving concepts and new entities, introduction of immunohistochemistry and genetic typing of the bone tumors. So the latest classification is a fifth edition of the WHO classification, came in April 2020. So which classified the bone tumors into 8 category: chondrogenic tumors, osteogenic tumors, fibrogenic tumors, vascular tumors, osteoclastic giant cell rich tumors, notocordal tumors, other mesenchymal tumors of the bone and hematopoietic neoplasms of the bone. So we will discuss them one by one. First we have chondrogenic tumors. They are divided into benign, locally aggressive and malignant. So we have subungual exostosis in benign, which is a surface lesion of the distal phalanx underlying the nail bed. Then we have bizarre periosteal osteochondromatous proliferation, which are surface lesions. They are composed of spindle cells, cartilage and bone. Then we have periosteal chondroma, which are the benign chondrogenic tumors. They are surface lesions beneath the periosteum. Then we have enchondroma. They are medullary lesions producing hyaline cartilage. Then we have osteochondroma. They are bony projections covered by the cartilage cap and have marrow cavity in continuous with the underlying bone. Chondroblastoma, in the previous classification they were categorized as locally aggressive, but now they changed this tumor to benign category. These are epiphyseal tumors composed of chondroblastic cells and eosinophilic chondroid matrix. Then we have chondromyxoid fibroma. Again, previously they were intermediate category. Now they have classified it as benign. They are lobulated tumors with zonal architecture. They are composed of chondroid, chondromyxoid and myofibroblastic areas. Then we have osteochondromyxoma. They are chondroid and osteoid matrix with extensive myxoid changes. In the locally aggressive category, we have chondromatosis or extra-articular synovial chondromatosis. They were previously classified as benign, but now as a locally aggressive tumor because of their locally aggressive behavior and high incidence of local recurrence. They consist of multiple hyaline cartilage nodules. They may involve the joint space, subsynovial tissue and tenosynovium. Then we have atypical cartilaginous tumor. They are previously were classified as synonym with the ACT and CS1, means atypical cartilaginous tumor and chondrosarcoma grade 1, but now they have differentiated the terminology based on if they are in the appendicular skeleton, then they call it as atypical cartilaginous tumor. If it is in the axial skeleton, the same tumor will be called as chondrosarcoma grade 1. Again, they are divided into primary and secondary. Primary means they arise de novo in the bone, and secondary means they had some pre-existing lesion in the bone like enchondroma, which later on converted to the intermediate category. Then we have secondary peripheral ascites. We have already discussed about it. And then in the malignant category, we have chondrosarcoma grade 2 and grade 3. Again, they can be secondary, primary and secondary. secondary will be mostly from the pre-existing osteochondroma. Then periosteal chondrosarcoma are the surface lesions in close association with the periosteum and invades the underlying cortex, or they have a size of more than 5 cm. Clear cell sarcoma are malignant chondrogenic low-grade epiphyseal tumors. They are characterized by lobules of the cell with abundant clear cytoplasm. Mesenchymal chondrosarcoma are malignant chondrogenic biphasic poorly differentiated round cells with well-differentiated organized hyaline cartilage component. Dedifferentiated are again malignant chondrogenic bimorphic histology with abrupt transition between conventional hyaline cartilage and high-grade sarcoma components. Then we have osteogenic. They are again divided into benign, locally aggressive and malignant. In the benign category, we have osteoma or bony island. Osteoma are the surface lesion in the cortical type of the bone, and bony island are osteomas within the medullary cavity of the bone. Then osteoid osteoma are characterized by small size, less than 2 cm, and they have a limited growth potential. Whereas the osteoblastoma are locally aggressive osteogenic tumors with morphologically similar to osteoid osteoma, but with high growth potential and a size usually more than 2 cm. In the malignant osteogenic category, we have low-grade central osteosarcoma. They are low-grade medullary lesions, consist of fibroblastic tumor cells with low-grade nuclear atypia and well-formed neoplastic bony trabeculae. Osteosarcoma not otherwise specified include conventional osteosarcoma, telangiectatic osteosarcoma, and small cell osteosarcoma. The conventional osteosarcomas are the intramedullary high-grade bone-forming tumors. Telangiectatic osteosarcomas mimics radiologically and microscopically to aneurysmal bone cyst. So they must always be differentiated from aneurysmal bone cyst. So biopsy is a must in ABC. Then we have small cell osteosarcoma. They are again the bone forming tumors with small round cell production. Parosteal are low grade surface lesions. Periosteal are intermediate grade surface lesions. They arise typically underneath the periosteum. Then surface lesions are they in this classification specifically they have separated high grade surface osteosarcoma. They are the high grade surface lesions. Then we have secondary osteosarcoma. In the previous classification, secondary osteosarcomas were included in conventional osteosarcoma section, but now they have described it in a separate section. They subdivided it into 6 groups. Paget disease of the bone related osteosarcoma, radiation associated osteosarcoma, infarct related osteosarcoma, chronic osteomyelitis related osteosarcoma, implant related osteosarcoma, or osteosarcoma secondary to early post-zygotic disorders such as fibrous dysplasia. The clear cell osteosarcoma and chondroblastoma like osteosarcoma, they were previously classified as subtypes of osteosarcoma, but these terminology have been deleted in 2020 classification. Then we have fibrogenic tumors. They are categorized into locally aggressive and malignant category. Desmoplastic fibroma are locally aggressive fibrogenic tumors composed of spindle cells set in abundant collagen. And fibrosarcoma are the malignant fibrogenic tumors. They are spindle cell tumor composed of relatively monomorphic fibroblastic tumor cells within variable collagen production and a fascicular architecture. This is usually a diagnosis of exclusion. Then the vascular tumor of the bone include benign, locally aggressive and the malignant tumors. In the benign category, we have hemangioma. They are composed of vascular channels. When involved in a large localized region and are widespread, they are known as angiomatosis. Then we have in epithelioid hemangioma, which are locally aggressive vascular tumor of the bone composed of cell with epithelioid morphology and endothelial differentiation. Epithelioid hemangioendothelioma are malignant vascular tumors of the bone, low to intermediate grade, composed of epithelioid endothelial cells within a distinct myxohyaline stroma. Angiosarcoma are malignant high-grade vascular tumor of the bone with endothelial differentiation. Then the next category is osteoclastic giant cell rich tumors. In the benign category, we have aneurysmal bone cyst. They contain multiloculated blood-filled cystic spaces. Non-ossifying fibromas are dysfunctional ossification. Giant cell tumor of the bone are locally aggressive osteoclastic giant cell rich tumors of the bone composed of neoplastic mononuclear stromal cells with a monotonous appearance admixed with macrophages and osteoclast like giant cells. The new category, the terminology have been introduced this in this classification, which is denosumab treated giant cell tumors. So this is a new variant of the GCT described. This is associated with blend neoplastic mutant spindle cells and a striking depletion of the osteoclastic like giant cells. In the malignant category, we have giant cell rich tumor of the bone. The same tumor rarely metastasize, rarely become malignant. Then we have notocordal tumors. In the benign category, we have benign notocordal cell tumor. They are benign tumors showing notocordal differentiation. Chordoma or chondroid chordoma are malignant notocordal tumors. They have a phenotype similarity to notochord and usually have axial location. Then poorly differentiated chordoma is the next category of malignant notocordal tumors. They are poorly differentiated with notocordal differentiation, usually arising in the axial skeleton and characterized by loss of SMARCB1 expression. Dedifferentiated chondromas are malignant notocordal tumors, have biphasic appearance characterized by conventional chordoma and high-grade sarcoma. Then next category is other mesenchymal tumor of the bone. They have benign, locally aggressive and malignant categories. In the benign category, chondromesenchymal hematoma of the chest wall. They arises from the ribs. Simple bone cysts are the intramedullary, usually unilocular, cystic bony lesion lined by fibrous membrane and filled with serous and serosanguinous fluid. Fibrous dysplasia are distorted, poorly organized, and inadequately mineralized bone and intervening fibrous tissue. They may be benign medullary fibrosis neoplasm. Osteofibrous dysplasia are benign other mesenchymal tumors of the bone. They have fibroosseous, typically arises in the anterior cortex of the tibia or fibula during childhood. Lipoma are composed of white adipocytes that arises within or on the surface of the bone. Hibernoma are composed of brown adipocytes that arise within or on the surface of the bone. Osteofibrous dysplasia like adamantinoma are locally aggressive, subtypes of the adamantinoma. Mesencymoma are locally aggressive. Other mesenchymal tumor of the bone consists of nodules of hyaline cartilage containing areas and bone trabeculae. Adamantinoma is a malignant other mesenchymal tumor of the bone, biphasic with a variable epithelial component within a blend of osteofibrous component. Leiomyosarcoma are malignant other mesenchymal tumor of the bone. They show smooth muscle differentiation. Pleomorphic sarcoma or undifferentiated sarcoma have no identifiable line of differentiation. These are usually the diagnosis of exclusion. The bone metastases are also categorized in the malignant other mesenchymal tumors of the bone. The next category is hematopoietic neoplasm of the bone. Plasmacytomas are localized intraosseous tumor composed of clonal plasma cells with no evidence of other bony lesions and no evidence of plasma cell myeloma. Then the lymphomas are categorized into various types. They are the when we will call it as primary lymphoma when they are composed of malignant lymphoid cells without any lymph node involvement and other extranodal lesions. Langerhans cell histiocytosis can be single system or multi-system. If it is single system, it can be unifocal or multifocal. Then Erdheim-Chester disease or Rosey-Dorfman disease are also classified as a hematopoietic neoplasm of the bone. Then Ewing sarcoma is not included in the bone tumor classification. In the section of the bone tumor classification, there is a separate chapter for Ewing sarcoma with the name undifferentiated small round cell sarcomas of the bone and soft tissue. So undifferentiated small round cell sarcomas of the bone and soft tissue, they have four categories: Ewing sarcoma, round cell sarcoma with EWSR1, non-ETS fusion, CIC rearranged sarcomas, and sarcoma with B-core genetic alteration. So if we talk about the Ewing sarcoma, they are characterized by gene fusions involving one family member of FET and the another from the ETS family. It is usually FET and ETS fusion genes. Most common is a EWSR1 and FLI1 fusion, which is almost 85%. And the second most common is EWSR1 and ERG fusion, which is almost 10%. Now, the previously used classifications, Askin tumors and primitive neuroectodermal tumors, are not recommended by WHO now. Then round cell sarcomas with EWSR1 non-ETS fusions. There are round cell sarcomas with EWSR1 and non-ETS fusions. They are round and spindle cell sarcomas with these fusion genes. The most common are EWSR1 and F8TC2. The other include FUS and F8TC2, EWSR1, PATZ1. They may have similarity to the Ewing sarcoma, but they are categorized separately because of their different behavior, their different genotypes, and their response to chemotherapy may be different. Similarly, we have CIC rearranged sarcomas, mostly in the soft tissues. So they are CIC-DUX4 fusion genes. And the next category is a sarcoma with B core genetic alteration both in the soft tissue and the bone. They have two groups. The first group is characterized by BCOR CCNB3 fusion, and the second group is characterized by B core ITD fusions. Then this was a classification of the bone tumor. Once we know the classification, we know the type of the tumor that the patient has. Now we need to stage the bone tumors. So the first attempt to stage the bone tumor was made in 1959 by AJCC. Then in 1977, Russell published a clinico-pathological staging system for soft tissue sarcomas. In 1980, Enneking then et al. They developed their staging system for both bone and the soft tissue sarcomas. If we talk about the Enneking staging system for malignant bone tumors, they have 1A category, which is low-grade intracompartmental, 1B low-grade extracompartmental, 2A which is high-grade intracompartmental, 2B is a high-grade extracompartmental, 3 is a metastasis. But Enneking system had drawbacks. Because the size of the tumor is an important prognostic factor, and they have not included the size in their classification, so it was a drawback. And there was no special consideration for tumors involving spine and pelvis because of the shape and the anatomy. They need different consideration, separate consideration. So AJCC now 8th edition, the classification is the classification used for these tumor staging. Lymphoma and myeloma are not included in this classification. T is the size of the tumor. If we talk about the appendicular skeleton, T1 is a tumor size less than equal to 8 cm. T2 is more than 8 cm, and T3 is a discontinuous tumor. In spine, T1 is a tumor confined to 1 to 2 adjacent vertebral segment. T2 is 3 adjacent vertebral segment. T3 is more than equal to 4 adjacent or any discontinuous. And T4 is a extension to spinal canal or the vessels. A is a spinal canal, B is a vessel. And if we talk about the pelvis, T1 is confined to one pelvic segment, T2 is one with extraosseous component or with two pelvic segment without extraosseous component. 3 is a 2 segments with extraosseous component, and 4 is a spanning all 3 pelvic segments and crossing SI joint. Then they are divided into A and B based on the size, and T4 is divided into A and B based on A is a extension medial to sacral neural phenomena, and B is an encasement of the vessels. Then N0 is no regional lymph node metastasis, N1 is a regional lymph node metastasis. M0 no metastasis, distant metastasis, M1 is a distant metastasis, M1A to lungs, and M1B to the bones. G1 is well differentiated, G2 is moderately differentiated, G3 is poorly differentiated. Now if we talk about the AJCC prognostic group, 1A is T1 means size less than 8 cm and low grade, T2 is size more than 8 cm and low grade, or discontinuous tumor with low grade means that stage 1 is a low grade. With stage 2A is a size less than 8 cm, T1 with intermediate or high grade. B is a more than 8 cm, intermediate or a high grade. Then stage 3 is a discontinuous tumor with a intermediate or a high grade. Stage 4A is any size of the tumor with metastasis to lungs. Stage B is uh, either it is metastasis to lymph node or it is metastasis to any distant site other than lungs. So metastasis to lymph node is a poor prognostic group. It is stage 4B and it is not stage 3. So this was a classification of the bone tumors. Thank you guys. Thank you very much.